Julie Taitsman is a Harvard Law alumna who also has an MD. And she has a position in the Office of the Department of Health and Human Services, Office of the Inspector General, which you have heard referenced by Dr. Rocky several times, called Chief Medical Officer. I did not know that position existed. Mm-hmm. And there's someone whose views on this, excuse me, whose views on this topic are exceedingly important, and we're delighted that you're here for us, Julie.
Thank you, and thank you for inviting me. I'm delighted to have the opportunity to talk to you all about institutional conflicts of interest. And I should say that, Dr. Korn, when you first invited me to talk here a few months ago, I was really excited about the opportunity to talk about institutional conflicts of interest, because I thought, this is a wonderful topic that isn't getting nearly as much attention as it deserves. And then I thought about it for a minute, and I realized, well, the Office of Inspector General hasn't been paying it as much attention as it deserves either. So I realized, well, what am I going to talk about? We have one study on institutional conflicts of interest. Usually,
several reports.
But only one specifically on institutional conflicts. Usually I have a whole body of OIG work I can discuss, and then also at the end of the day, so I had to try and come up with some more obscure topics that wouldn't be taken earlier. So I want to start by talking about OIG's role in research oversight, and then conflicts of interest for institutional review boards, and finally the institutional conflicts that arise when hospitals and universities accept educational funding from drug and device companies. And in the middle there are one study that I mentioned. Now, I don't know how familiar this audience is. I wasn't sure who would be in the audience and how familiar you are with the Office of Inspector General. So should I spend a minute telling you who we are, or does everyone know? Okay, well, the Office of Inspector General for Health and Human Services. There are lots of offices of Inspector General throughout the government. Many departments have them to provide internal oversight for their operations. HHS is the largest Office of Inspector General because our mission is not just oversight for the agencies within Health and Human Services like FDA, Indian Health Service, NIH, but also oversight for all of the hospitals, drug companies, physicians, durable medical equipment companies that receive Medicare and Medicaid funding. And actually, the vast majority of our work, about 80% of our work, is outward looking towards the recipients of Medicare and Medicaid funds. Minority of our work is internal to regulation of the other agencies within HHS. So this is our headquarters in DC. I mentioned we have 1,700 people. Not all of those folks are in DC. We have offices actually in every state. We have about at least 50 field offices. So we have at least 2 people in every state. We actually have a very big office in Boston in the JFK Federal Building that has all of our components represented. And what our components are is our largest component is actually audit. The largest type of professionals we hire are auditors. And they do exactly what you'd think. They audit recipients of federal funds. Many of their audits are looking at recouping overpayments, looking at program violations. Our next biggest is our Office of Investigations, and they are law enforcement types. They're special agents. They carry badges and guns. Most of them actually had no background in healthcare. If you're familiar with applying for federal jobs, they are 1811s. It's a very coveted position in government because they get a 25% pay bump compared to everyone else and early retirement. And it's folks who were looking. The vast majority of our investigators had no interest in healthcare before. They were looking for an 1811 job, and they look at FBI, they look at border enforcement, and they end up it's whoever's hiring at the time. So they end up at HHS. And they do our investigations and our enforcement actions with our Office of Counsel. We have a whole lot of lawyers, and we also work in partnership with Department of Justice and other law enforcement partners to enforce the fraud and abuse laws, the AntiKickback Statute, the False Claims Act, the Stark Law, all of those healthcare laws. And then finally, we have a very small office, about 100 people, who are our evaluators. And those tend to be the folks that the academics know most about because that's where the studies come from. Most of our reports are from the Office of Evaluation, that you see on the internet and get a lot of attention in the press, but that's actually a small minority of our employees. And we sort of talk about them as like a little think tank within OIG, because their reports don't have to be geared towards getting money back. They don't have to be geared towards sending anyone to jail. They can just study a policy, something that we're interested in, and make recommendations. Like one of the reports that I really liked from our Office of Evaluations looked at specialty hospitals and how they handle medical emergencies after hours. Now, some specialty hospitals are real hospitals and they just focus on cardiac care or orthopedic care. And some specialty hospitals are surgery centers that have beds and let patients stay overnight. And their emergency protocol after hours is call 911. They don't even have a nurse, let alone a doctor who could run a code. And so that study looked at how specialty hospitals handle emergencies, and then since no programs were being violated, there's no enforcement, but we make recommendations to CMS, hey, maybe you should change your requirements for specialty hospitals, maybe you should beef up the type of staff that need to be there. Now, so why is someone from OIG here talking about conflicts of interest? Why is it our business? Why do we care? Our mission is to protect the integrity of health and human services programs and the health and welfare of program beneficiaries. Now, there are two important components of that mission: protecting the federal money, and then, which means making sure that we get what we pay for, and then protecting the patients, making sure that what we get is good and that our program beneficiaries receive high quality care. Now, we don't directly regulate universities or academic medical centers. I spent some time on the Hill working for the Finance Committee, and we like to call it the elastic jurisdiction of the Finance Committee when we wanted to investigate something that wasn't really our business. So Finance Committee, funds Medicare and Medicaid, but the HELP Committee, Health, Education, Labor, and Pensions, really has primary jurisdiction over FDA. But Finance Committee has a lot of interest in FDA and, likes to do investigations into drug approvals, or one investigation we were working on while I was there was research fraud related to a new antibiotic. So what we would do is we'd still want to get the information, so we just send out a request, and we'd start with this sentence that we cut and pasted from every previous request for information, saying, well, Finance Committee has jurisdiction over Medicare and Medicaid, and once a drug gets approved through the FDA, Medicare and Medicaid will pay for it, so we have jurisdiction over what you're doing, and we want this information. And it's a similar indirect authority that OIG has in this area. We are the oversight agency for HHS and all agencies within HHS, so NIH and FDA. Now, we don't directly conduct medical research, and we don't fund research or education. NIH is a major funder, tremendous amount of money from the NIH budget. I've seen that the medical research budget exceeds $30 billion is the numbers that I've seen. And much of that money is used for extramural research at universities and academic medical centers. Now, what we see is a potential risk from institutional conflicts that our money, this federal money, could be misspent. But aside from the money, we also see oversight as a quality of care issue, both care for the people who serve as human subjects in the clinical trials, but then also care for the patients who would use products that ultimately get approved based on the trial, and then Medicare and Medicaid beneficiaries who would receive those drugs, biologics, and medical devices covered by the Medicare and Medicaid programs. Now, Dr. Korn already went over this definition from the Institute of Medicine. I like that definition a lot. And then primary interests, institutions like researchers have all types of primary interests. Professor Marks talked about the primary interests for research institutions. And again, we just like to remember that the people that we're protecting here, it's the two groups of people, both the human subjects participating in the trial, and then ultimately the patients who aren't part of the trial, but will either get to use the product that gets approved or be denied access to a product that doesn't get approved because the trial failed. And I'll mention institutional review boards. Their main interest is to ensure that the study is properly conducted and to protect the subjects and ensure the data integrity. But there's danger, and again, I don't think I need to mention the secondary interests for the institutions, for the hospitals and universities, but I will mention the interests for the institutional review boards. And basically, our concern here is the financial conflicts, that they can be an important secondary interest, especially for independent IRBs. Now, Traditionally, institutional review boards, from the name institutional review board, they were set up by the institution, the hospital or university that ran the research program. But now there are a lot of independent institutional review boards, which are mostly for-profit companies that oversee research at other institutions. And basically, they make more money the more studies they oversee. So there's a real risk that their financial pressure is to keep their customers happy. I mean, they understand who their clients are. Their clients are the researchers that are coming to them to get a drug trial or a device trial approved, and then also to continue that trial with minimal oversight, minimal meddling from the IRB. So they have real financial pressure to approve trials quickly and ultimately to approve them as opposed to rejecting them, and then to have minimal oversight burdens throughout the course of the trial. Now, do these conflicts of interest exert an effect? We don't really know. I've seen some studies that show that research that's funded by the drug manufacturer is more likely to have a favorable result, is more likely to be published quickly. Also, not just the risk that a negative trial won't be published at all, but that if they do ultimately publish it, they will drag their heels and not get to it that quickly. And then also the risk that the same data will be reported more favorably with the conclusion that the drug is effective and that the drug is safe. Now, just mention data integrity for a minute. And what we're talking about there is accurate and reliable collection and reporting of the research results. So we worry that institutional conflicts could lead to compromised data integrity. For example, if the university holds patents or hopes to commercialize an investigational product. Again, our role at OIG is indirect. It's FDA that will ultimately decide whether the drugs, biologics, and medical devices can be sold in the United States. The companies that want to market the products have to submit the application to FDA with research data supporting the product's safety and effectiveness. We don't review marketing applications, and we don't assess efficacy of drugs. Our concern is to conduct oversight to make sure that FDA makes sound efficacy and safety determinations. And then once products that FDA approves get entered in the market, we think our oversight helps ensure that the consumers are protected from unsafe and ineffective drugs, and also that products are not unfairly denied entry to the market, where our beneficiaries would then be denied access to the product. We don't usually focus on that flip side of denying access to products that should be approved, but that's really just as important to us to make sure that FDA makes the right decisions, both in approving products that should be approved and in not denying entry to products that are potentially beneficial. And then for these approved products, the federal healthcare programs pay for a lot of the drugs and devices. And again, CMS runs the healthcare programs. Oftentimes when I talk to physician audiences, often OIG is called the enemy, and they'll talk to us about, what you guys are doing. You're not covering this, you're not covering that, you're not paying enough for this, you're not paying enough for that. OIG does not run any of the programs. Our role is indirect. We provide oversight to CMS, the Centers for Medicare and Medicaid Services, that does run the programs. So our goal is to help make sure that CMS is making sound coverage decisions so that the programs don't pay for drugs that are worthless, and that our beneficiaries get access to new technologies that are beneficial. Now, for financial integrity, we're concerned about the money the government's spending to support research, and then also the money that we're spending to purchase healthcare services. The United States remains the world leader in developing new medical technologies. Part of that success comes from private investment, and part also from public investment. A Congressional Research Service report recently said that the government spends over $70 billion to support scientific and medical research, part through NIH and part through other agencies. We oversee the portion funded through Health and Human Services. And annual U.S. healthcare spending is measured in trillions of dollars. The federal government is a major purchaser of healthcare items and services. About 100 million Americans receive care through federal healthcare programs. And annual federal spending on Medicare, Medicaid, and CHIP is about $770 billion. So most of our efforts at OIG is aimed at making sure that that $770 billion is well spent. Now, when universities and research hospitals have equity interest in investigational products, there's a potential conflict. There's also a potential conflict when the institution receives funding from the company that owns the product. Now, putting aside vested interest in how the research results will come out in a certain way, we're also concerned about even the simple financial incentives to enroll more patients as subjects in the trial. We call that headcount compensation, and that's something that OIG has expressed concern about when the drug company pays physicians often a very high amount for each patient the physician can enroll. We think it's much safer to have compensation arrangements based on the amount of time and effort that the physician expends in enrolling subjects, as opposed to purely a success-based payment based on successfully convincing a patient to participate as a subject. Now, our thoughts on clinical research standards protecting human subjects. We think informed consent is very important, but it's not the only thing that's important. Acceptable studies should be well designed, and that goes well beyond informed consent. You should make sure that there are all of these features of a valid design. Clearly, there's no point in conducting a study when you already know the answer. And OIG is on the lookout for seeding trials and other marketing schemes masquerading as clinical research. Are folks familiar with the term seeding trials? It's what we call when a drug company has a drug that they think works, they're pretty sure it works, it's either already been approved or it's about to be approved, and they just enroll a whole lot of clinicians, and they tell the clinicians you're participating in a trial, and really the goal is just to get the clinician to prescribe the drug to their patient. Sometimes the doctors know, sometimes they don't know. Sometimes the doctors really think that they're clinical investigators and they're participating in the trial, and they don't understand that it's the marketing department that's running this trial, and no one's looking at the data that the physician is collecting. Sometimes the companies don't even ask the physicians to collect data. So in those cases, the physicians really know that they're just getting paid to enroll their patients. Other times, we've seen some really well-meaning physicians who genuinely think they're conducting research, and they're surprised to find out that those worksheets that they're dutifully filling out and handing to their sales rep are just getting thrown out, that marketing has no interest in that. Often when people talk about human subjects protection, they focus only on informed consent. And informed consent is very important, but it's very important not to lose sight of the other features of a good research design. And the next example that I'm going to talk about illustrates what happens when the oversight people focus only on informed consent and not on other aspects. Now, OIG has a long-standing interest in institutional review boards. We have an old series of reports back in the 1990s. They're all available on our website. And we explored the rise of independent IRBs. So we noticed that IRBs were increasingly, that researchers were increasingly using independent IRBs instead of the IRBs at their institution. And we were concerned about the financial incentives to improve more protocols and oversee more trials. And that could be a really good strategy for an independent IRB to promote business, to become known, to get a reputation for having a less than rigorous approach to oversight. Now, I don't mean to be slamming independent IRBs. There are some legitimate advantages. They might offer faster review times. They might be free of hospital politics and other conflicts that can arise from an institutional IRB. And they might also be useful for a unified review of trials involving multiple research sites. But we are concerned about a significant conflict of interest risk. Again, because most of them are for-profit, and the customers like to have a quick yes, a quick answer to their protocol. Now, our series of studies found that independent IRBs were growing, and they were increasingly reviewing more studies, including Health and Human Services funded research. And we were concerned that they would perform a cursory review geared towards keeping the customers happy. We also saw a potential for IRB shopping. Sponsors can look around for an easy review, or if they're rejected by one IRB, without making any changes to their research protocol, they can just submit it to another IRB and another IRB, as many as it takes until they find one that approves it. Now, GAO conducted an investigation to follow up on our work. And GAO made up a fake study protocol, and their protocol called for pouring about 1 liter of an investigational fluid into patients' abdominal cavities following abdominal surgery to see if the fluid sped up wound healing. And they submitted this protocol to 3 independent IRBs. And 2 IRBs rejected it. Got 2 quotes from the reviewers. One reviewer called it the most dangerous protocol he had ever seen. Another reviewer called it absolute junk. But the third independent IRB, Coast IRB, approved the protocol with a unanimous vote 7-0. And the IRB reviewer specifically noted the adequacy of the informed consent. So the quotes for the reviewers were, the informed consent looks good, the informed consent looks adequate. So Coast IRB was seeming to focus only on the informed consent at the expense of checking that it was a worthy study design for anyone to sign on to. So Coast approved the study, and then they also sent GAO this coupon for a discount on their next study protocol. And the coupon, if you can't read it, it says, Coast through your next submission. Coast is now out of business, but that's a long build up to our one OIG study. Now, if you're familiar with OIG work, you may have noticed that OIG reports often come out in a series. There are a variety of reasons for that. Sometimes it's a congressional mandate, like we recently released a whole series of work on adverse events that happen to Medicare beneficiaries in acute care hospitals that's going to be followed by a series on adverse events in nursing homes. And that was because we had a congressional mandate to undertake that work. Sometimes a series just reflects that individual staff in one of the regional offices has developed an expertise. So once they do one study on Part D or conflicts of interest, they realize that, well, I want to be the go-to region on this topic. I want to be the FDA region. And so the staff has this expertise, and they decide to do more studies on that same topic. Anyway, our Philadelphia office completed a series of reports on conflicts of interest. The first report in the series looked at how well NIH kept track of financial conflicts by grantees. The second study looked at how grantees manage interests. Not till the third study did we focus on institutional interests. And here's that study. You can read the whole report on our website at oig.hhs.gov, and the other reports are up there too. Now, federal regulations require recipients of NIH grants to report conflicts held by individual researchers, but there's no such federal policy for grant recipients' own institutional conflicts. And this study looked at whether grantee institutions had their own institutional conflict of interest policies. We found that 70 of 156 grantees have written policies and procedures addressing institutional interests, and 69 grantees have written policies and procedures addressing institutional conflicts. 18 grantees identified 38 institutional conflicts. And here's what we recommended. We recommended that NIH should promulgate regulations addressing institutional conflicts. Now, we all know research funding isn't the only way industry gives money to academic hospitals and research universities. We all seem to have bought into the idea that it's safer to give money to an institution than to an individual. If you consider travel policies, many universities, drug and device companies, the Pharmaceutical Trade Association, they have travel funding policies that allow the drug companies to fund residents and fellows to attend educational conference. But the provision is that instead of giving the money to the doctor directly, they'll give the money to the hospital or university or the academic department, and then the institution gets to decide who gets to attend. And we also see endowed chairs sponsored by industry. I just read an article a week or two ago about Synthes. Synthes pays $2 million a year to the University of Washington to have an endowed chairmanship in the Department of Orthopedics. And then this article goes on to allege some improper off-label use of a bone cement marketed by Synthes. And it raises the question, is it really safer for the company to pay the university to sponsor an endowed chair instead of paying the doctor directly? Some people might even argue that paying the doctor is more safe than paying the university, because paying the university lets the company exert even more influence. The doctor still gets the money, and now also the prestige of an endowed chairmanship or an endowed professorship. And there's a big kickback risk of paying the hospital. The hospital could be a big customer of the drug or device company. The hospital controls formulary decisions for drugs. The hospital decides what medical devices will be available in the operating room or on the floors. There's a real risk of the hospital exacting a kickback from the company in exchange for this business. The hospital might not just be a good customer for using the device or the drugs itself, but for thought leader institutions that create clinical practice guidelines or influence practice patterns at other hospitals by promoting use of the sponsor's product. There's perhaps an even greater kickback risk the more prestigious the institution. Now, I want to briefly mention academic institutions accepting industry money for other educational purposes, such as continuing medical education. An Institute of Medicine report said that medical schools receive 62% of their CME revenue from industry sponsorship. Happily, we're seeing a recent trend of some universities moving away from industry funding, and I think that's a terrific direction to be moving in. There was a Senate Finance Committee report a few years back that pointed out some of the potential vulnerabilities when hospitals and universities accept funding for continuing medical education or for clinical practice guideline development. So there were some stakeholders who read that report and said that a good solution would be to cut out medical education and communication companies, those for-profit education companies that run CME, from the CME business, and only allow hospitals and academic institutions to run CME that's sponsored by industry. When OIG looks at that proposed solution, we actually see an even bigger kickback risk. OIG hasn't taken an official position on this, but there's a sounding board article written by me and our chief counsel pointing out how there are significant potential institutional conflicts when hospitals and universities accept drug and device company funding. If not adequately controlled, these conflicts could exert a harmful effect on physician education and on patient care. We're seeing some private sector trends reducing grants to medical education and communication companies, awarding multi-year institutional grants, and distancing industry sponsors from specific CME programs. Things that we would like to see in the future, possible limits on industry's educational control, would be pooled funding mechanisms, activity level accreditation, so only a useful educational program would be accredited as opposed to giving an accreditation to any institution and then saying whatever programs you decide to develop are accredited, and ultimately elimination of industry funding. OIG will continue our conflicts work, including studies and enforcement of the Anti-Kickback Statute. One item I want to mention from our work plan is a study that we are hoping to get to by 2014. As many of you might know, there are several privately published drug compendia that exert tremendous influence on whether or not a drug will be paid for by Medicare and Medicaid. The programs cover drugs for all on-label uses as well as certain off-label uses, and those are the off-label uses that are favorably listed in these approved compendium. And drug companies have a powerful incentive to submit proposals to a compendium that will list their drug favorably for multiple indications. So one area that we plan to explore in this future study is to look at conflicts of interest in the companies that publish the drug compendia, because those compendia exert such tremendous influence on what drugs are covered and paid for by Medicare and Medicaid. So that item is in our work plan. Our work plan and all of these other studies are published on our website, oig.hhs.gov. The website is a terrific resource. And then I guess now Sally and I will answer questions.